Good morning, everyone. I'm personally thrilled to be here and really excited that Dr. Kaiser agreed to chair this workshop because in essence, this is a good set of problems to have, right? And it's really a tribute to Ken's leadership. When he came into VA, if I have this right, it was hospitals only. And so there wasn't a scheduling problem. I mean, you came and there might have been bed supply problems, but this whole panoply of challenges that we're struggling with today is really a tribute to his leadership in, pretty radically transforming the Veterans Health Administration, and that transformation in some way continues. So, before I get into the specifics, which can be a little bit eye-glazing, what I wanted to give you was a picture. For those of you who've ever had a problem with a flight delay, you're going to miss a connection, there's weather, whatever happened, and you have the wonderful experience of meeting a gifted agent at the gate who says, oh, yes, I can get you on this other flight, and you're not going to have to worry about the connection, and it's leaving pretty soon. And, this is just like magic. And then that person gets to work and starts typing and typing and typing and typing. And you're thinking, I hope this is like still working out. But you're also then thinking, couldn't they make this system easier? Our scheduling system today is that same vintage. And by the way, like the airline agents, some people start to get upset. I'd love to tell you I've never expressed a little bit of frustration like, can you speed this up? Or how long might this take? But when people are sick and worried and afraid of what might be going on with them, they will get frustrated. So we put a lot on the group of people we refer to as medical support assistants or scheduling clerks. So I wanted to have you have that mental picture as I walk through some of the details. A colleague said to me recently that an electronic health record is probably the worst name we ever came up with for anything because it sounds like a Word document, a little record, like how hard is this? When it's really a health management system. So our health management system, if you will, is called VISTA, the Veterans Information Systems and Technology Architecture. And as we prepare to implement a commercial product with Cerner over the next number of years, it becomes clear mostly just how many systems are embedded in what we call an electronic record. In recent years, we've tried to enhance our scheduling system that we've had for quite a long time. I'm talking the mid-'80s, just to ground you. Some of you may not have been around at that time or too young to appreciate what a computerized scheduling system might be. But we have had a VISTA scheduling enhancement, which brought about some improvements, and I'll just leave it at that, modest gains. We have our computerized patient record system as well. In addition to that, we have point-of-service kiosks for veterans, so our Pittsburgh VA almost looks like an airport lobby, lots of kiosks around. In recent years, under the leadership of Drs. Lieberman and Kirsch, we have a way to remind veterans of their appointments using texting. Texting, by the way, seems to be the new innovation, customizing it for different purposes. We have an online scheduling system, not unlike ZocDoc, although it's homegrown for our system. And we have made huge advancements in telehealth. So we literally now can cross state boundaries, and we are not constrained by the need to figure out a billing or revenue source for it. So it is not an uncommon statement to hear a facility in Texas desperate for another mental health provider to say, we just hired one, that person lives in Wisconsin and they're not moving, because we can do a great deal of work by telemental health, and we do. And for those of you who've heard bad jokes about why do we have so many psychiatrists in Manhattan, it turns out the Manhattan VA provides a lot of virtual mental health care all across the country. We have Video Connect for patients and specialists in particular to have a live visit face-to-face. We have a patient portal known as My Healthy Vet, and we have secure messaging, and we track how often these functionalities, as we have transformed in the past number of years to a patient-centered medical home model where primary care is definitively a team sport, how often some of these functions are used. So a lot of moving parts. So the program schedulers have to learn and check daily, right? Unique information provided in each of these components with differing formats. And there's very, very little that's automated about this system. The Cleveland VA is among our best. And when I've watched them, provide an overview of how they're doing with access to care in both at the main facility as well as the outlying community clinics, I can tell you there's no shortcuts. It is one foot in front of the other, and they do a phenomenal job, and they're on it all the time, but there's no app for making it a little bit easier. And much of this information has to be entered manually. One of the challenges is the issue of person-dependent versus system-dependent, and I shared Lisa Lehman's interest in what we mean by system strategies. The challenge, of course, is that I don't believe that there's a person working for us who's not passionate about serving veterans. Although, like physicians' views of patient-centered care, sometimes not everyone has exactly the same idea. They can all agree on the general concept, but in specifics, what this results in our system is avoidable errors. So we've created an auditing system to identify errors and opportunities for re-education, and it's labor-intensive. And by the way, a lot of our docs work part-time because they also have academic appointments, well over 50%. So every possible new challenge that you could wrap into this, we've got, and that's baseline, and that's our system. It is difficult to identify urgent needs. This is both a conceptual problem as well as a challenge of not having a predefined issue for or way to codify that in the record. So we have built manual patches, if you will. The new system, we hope, will address gaps in the current system by increasing automation to reduce errors and save staff time, improving communication across care delivery platforms. In theory, we are evolving to a point where really we can see veterans one of three ways: in person, virtually, or asking a community partner to help out for a specific need. In theory, that ought to be one integrated dashboard. That is not actually where we're living today. Where we're living today is they're a bit siloed, but we want a scheduling system that can handle all of that. And we are doing a considerable amount of business by telehealth. And we want enhanced functionality for the way we provide care. I won't go into the issue of multiple stop codes except to say that it's a description for a type of clinic visit. And there are physicians in our system who, in days of not too long ago, actually were associated with about 30 different stop codes. Some of that has been simplified, and it really was not about appointments for left kidneys, but some people are trained in multiple specialties and so on and so forth. So the new system has to take into account, I think I just did this backwards thing, right? Our specific needs and requirements, including telehealth, as well as interoperability needs. So we also have additional considerations by virtue of what makes you eligible to get care in our system. So that relates to the degree of service connection, the prioritization of urgent clinical needs. I mean, in real life, whether you're working in a free clinic where you're completely free of paperwork because there is no billing, to a very, very sophisticated system, there is no predefined taxonomy that's very, very clear about what we mean by urgent. And In fact, I learned something very, very key about this a lot of years ago. I knew that I was sick, although I was pretending I would be just fine. I went swimming and so forth, thinking I could talk myself out of this. And for other reasons, that is to say, I was changing jobs. I had a blood test, and then I knew actually that crashed through my denial. So I called the physician's office and said, I need to be seen today. And their response, not unlike where I get care now, was, well, sorry, we're busy. So I, of course, did what most people do when they feel really desperate, which is I had a little fit, and I got in that day. And I was telling my sister later, who was then the mother of 2 very young children, about this, and she said, uh-huh. And I thought, right, if you're a parent, you do this all the time. And after a while, I even started coaching patients. If you've got something you're really, really worried about and somebody says 2 to 3 weeks, let me tell you what works like a charm. Make noise. If that doesn't work, make more noise. And ultimately, you will get in. And showing up is often very, very helpful, and veterans do exactly that. Our system also has to have functionality for referring to community care. And we have some unique programs that are a big part of our system, part of the fabric. Programs for spinal cord injury, residential treatment. We've got quite an extensive footprint in home-based primary care, and that's just a few examples. So again, just special requirements that we have are for telehealth. Now, this scheduling functionality is both intra-facility as well as inter-facility. And resource-based scheduling is essential to get at the demand-supply challenge. And visits by telehealth, just to remind those of you who don't deal with quite the same volume, can either be synchronous, where the patient and clinician are sort of operating in real time, or asynchronous, store and forward, and we do quite a big volume of both. So virtual visit requirements, the VA Video Connect visits need to be interchangeable with face-to-face visits. Again, we're not there yet, but that's where we need to go. The schedulers in the call centers who partner with our primary care teams, PACT is Patient Aligned Care Teams, that's our acronym for Patients at a Medical Home, have to be able to schedule video visits, particularly to avoid a challenge when people don't show up for care. And other practitioners in call centers need to be able to expand a tele-urgent care offering. So a lot of moving parts, and it's really, really exciting that we have all these capabilities. What we don't have is a unifying framework and system underneath it. And we've got to be able to coordinate appointment reminders and cancellations for patients. One of the challenges we have now, as I understand it, and Steve or Susan, if I say this badly, let me know. I learned this from some people who were trying to implement a tool that would predict which patients were most likely to not show up. Now, I will say in our system, most people are very, very comfortable with sending extra reminders to that veteran. Most people are very, very nervous about overbooking. I haven't asked the surgeons. I have a suspicion they would probably be more comfortable with it, since every place I've ever worked, surgeons overbook. But what they learned was, when the information, if you call in and say, I can't get there, my car broke down, or whatever, it depends on the time of day, at what point in time that information actually gets to the scheduling system. If you call in the morning for the afternoon, it probably won't get there on time. It'll be there the next day, but that doesn't actually let anybody know that we've got a room empty from 2 to 3 or whatever the time was. We have to have a consistent system across VA centers nationally. Clearly, that is one of the rationales for going with the Cerner implementation. And we have to exchange information between VA and the Department of Defense. Now, early on, when I came to VA a little over 5 years ago, I couldn't quite get this. I figured, they were in defense, now they're with us. Like, besides history, what is the big deal? Well, it turns out a lot of veterans are enrolled in Medicare. Some actually are enrolled in TRICARE, and they're eligible by virtue of service connection for care in VA. In general, they tend to know more about how to work all systems than our scheduling clerks do, and frankly, almost anyone working in our system. So that's why the interoperability is very, very important. And we need to build this system out so that we can't just simply get rid of all the systems we have and start with the new one. It's far, far more likely to be a phased transition. So, in general, how we envision a future state is a single program supporting all aspects of scheduling, which I would assert is actually much, much more complex task than managing medical information. Not that that is trivial either, but even if you think about it, it underpins a lot of our medical understanding of changes in clinical status, clinical course, and so forth. We were very, very excited about this workshop so that we could gain insight and develop recommendations for the new system. We've got internal and experts in the field as well as internal and external stakeholders, and I just think this is a phenomenal opportunity to define the future. So I think it was a magnificent idea to call on the National Academy of Medicine to help us out here. I was very, very excited by getting to now, and you know, when Gary Kaplan and a couple of other people on the committee came in, I learned two things. They were wildly excited about the potential for VA to get to a better future faster than almost all of U.S. healthcare, and they were still reeling from the shock of learning that there are almost no data anywhere about how long it takes to get an appointment or anything else. A few random, ER wait times, but that's it. And, Ken made the point that at his system, we don't even count how long you're in the emergency room. So it's kind of a wild and woolly picture out there. But thank you again for your participation and contributions in advance.
Before you leave, Carolyn, let me ask if there are any questions, again, from folks here in the room or those on the phone. And I'm actually going to take the chair's prerogative and ask a question. And you mentioned about the special VA special programs. And many people are probably not familiar that the VA really kind of pioneered the idea of the spoken hub model of referrals, which is, of course, is well known in trauma care today with the level 1 trauma centers, et cetera. But VA actually started this in the 1940s first with blind rehabilitation, and then has put it in place with a number of other specialty systems over the years. And so my question really, given that whether spinal cord injury or blind rehab or some of the other special care programs that really are not available in the community, or at least available with huge constraints on them. How do you see some of the challenges and then the issues attendant to scheduling those folks? And again, not every network has a spinal cord injury center, and there's a need to refer often substantial distances. I wonder if you could comment a little bit more about those special programs.
Yeah, so inherent in the hub and spoke idea is that many people are traveling a considerable distance and are usually coming for a residential stay of some period of time. That's going to depend on the acuity. For example, someone who is recently become blind and has had no training or rehab previously will need a longer stay than someone who's having a very specific focused problem. A similar sort of approach for spinal cord injury patients. Much of this that I find incredibly interesting is like many large systems, ours being probably about the largest in terms of geographic spread, we have pretty much assumed that it was perfectly okay for veterans, and we supported travel, to be fair, to go park themselves at a center of excellence when they needed to do that. In some ways, we are discovering more and more ways that we can use virtual health modalities to deliver some of that care. But frankly, some of these specialized services have sprung up elsewhere. My best guess is that most veterans would prefer to get that at VA. In some communities, there are other spinal cord injury centers where you can get rehabilitation. I'm thinking of the place in New Jersey, for example, sometimes referred to as the place where Superman was after Christopher Reeves had his very serious injury. By and large, I don't see those specific programs going away, but I think we're going to be learning there as well how much we can do virtually, depending on the kind of caregiving situation and unique characteristics of that veteran.
From Atrius Health up in Boston. Is this on-ish? Good enough. Dr. Clancy, thank you so much. I'm linking together the concept with the Mission Act 2 that Dr. Lieberman talked about and the use potentially of more community partners. You started talking about sort of that aspect of how do you meet criteria for eligibility of going out there. For in the commercial space, it starts to think about prior authorization processes, et cetera. Is that something that's sort of some of the requirements as we go into that new space for the VA, and how much will that land on the scheduling systems to coordinate?
Ultimately, it will land on the scheduling system to support. What we are doing today, because this goes live June 6th, is we have developed inner testing, and we've got a sandbox for people to learn how to use a decision support tool that actually gets to a practical application of the access standards that Dr. Lieberman described. Ultimately, though, that's kind of the front-end decision piece, right? And what we want is that the clinician in the community and our clinicians are sharing information. Very, very easy to say, much harder to do given the current state of interoperability in general, but yes, this system is ultimately going to have to include that as well. And I should just note, because I think it's a logical next question, to the best of my knowledge, we do not have an ordering of what comes first. So I would not see this as necessarily being first, but we haven't numbered them down with all the aspects I described.
Hi, I'm Rachel Weber. I'm an independent consultant with Healthcare IE, and you mentioned that over 50% of your providers are part-time and have their own practice. And so I was wondering if a patient can't get in with their own provider within the guidelines, would the next option, or would an option be that they could get in with another place that they practice outside of the VA, or would you try to keep them within the VA if a fellow provider had the availability?
So the vast majority of our clinicians who are part-time will also be, some may be providing care at their academic site as well. But that's also going to get into now, do they meet the criteria for getting care in the community? And we have a variety of contractual arrangements in terms of working with our affiliates to handle overflow and so forth. And I will simply say that they're not consistent or reliable across the system. I mean, many idiosyncratic arrangements that work extraordinarily well for this one VA and this one affiliate. So that has not been systematized. What we wanted, based on the results of the success in Columbus with this EPIC product, was, yes, it will be connected to our underlying computerized patient record, for sure, but that we could get some relief to those sites that won't be getting Cerner for 8-9 years. In general, this is a west to east migration, largely because we're working very closely with the Department of Defense. Why they picked the Pacific Northwest, I don't know, but that's where we're starting to, sort of trailing along behind them. That means people on the East Coast aren't going to see this record for 8 or 9 years. And it became, in the face of these results from Columbus, a little intolerable to more or less say, well, there's a great scheduling system that'll be happening, but, unfortunately, you may not be working here anymore once we get it here. So that was actually the trick.
Other questions, comments, folks on the phone?
Great.
Thank you, Carolyn.